Hi, very good morning. I'm Dr. Janak Patel, MD, General Physician. All my video lectures are mainly for educative purpose. In continuity with the previous lecture series in neurology examination, or we call nervous system examination. Today we'll be talking on examination of cerebellum and cerebellar functions. Now, to understand that, we'll be first highlighting little amount of anatomy and then little function, and then we'll go to the function part of it, and then examination. For examination of cerebellum, you will need all these things like vibratory instrument, pins, then hammer, etc. Those are some of the things which may be required while examining the cerebellum. So little amount of anatomy, connections, functions, then what are the disease which will produce damage to the cerebellum, little about of the clinical features, then how you examine those findings what you get in cerebellar disorders, and then how you localize. So cerebellum has got two hemisphere, and central part we call as a vermis. It is attached to brainstem by superior, middle and inferior peduncle. There are three peduncle by which it is attached to brainstem. Through those peduncle there are incoming fibers we call as afferent fibers, and there are outgoing fibers we call as efferent fibers. So there are incoming and outgoing fibers. Also, one cerebellar hemisphere is connected to the opposite cerebellar hemisphere via cerebellopontocerebellar fibers, which is mainly running through the middle peduncle. Cerebellum is connected to lot of different parts of the brain. As far as the different lobes are concerned, we have got an anterior lobe, we have got a posterior lobe, we have got a flocculonodular lobe. It is situated posterior to the brainstem and in the occipital fossa above the cerebellum. Between the occipital lobe and cerebellum there is what we call as a tentorium cerebelli. Posteriorly you have got occipital bone, inferiorly also you have got occipital bone, anteriorly you have got a midbrain pons and medulla. Major part is behind the pons. Between brainstem and cerebellum there is a fourth ventricle. This is roughly the little amount of anatomy part of it. So you got a two hemisphere, anterior, posterior and flocculonodular lobe. Gray matter is outside, white matter is inside. There are four main nucleus: dentate nucleus, emboliform, fastigial and globus nucleus. Both hemisphere are connected by a central part we call as vermis, and that is giving rise to the fiber we already mentioned, cerebellopontocerebellar fiber, which will be running through middle peduncle. It is attached to the brainstem by three peduncle, upper, middle and lower, or we call superior, middle and inferior peduncle. Via this peduncle there are incoming fiber we call as which enters the cerebellum, or we call afferent fibers. Outgoing tracts, that is efferent fibers. Two hemispheres are connected by vermis, cerebellopontocerebellar fibers, and it is situated in posterior fossa we already mentioned. On the top there is a tentorium cerebelli, anteriorly there is pons and medullary part, and between those two there is fourth ventricle. So there is an anterior lobe, posterior lobe and flocculonodular lobe. You got a two hemisphere and central part is called vermis. There is one fissure called primary fissure which separates anterior from posterior, and there is also one fissure called as a horizontal fissure, and there is a posterior fissure which separates posterior lobe from flocculonodular lobe. Anterior lobe is concerned with maintenance of tone, posterior lobe is concerned with coordination of movements, and flocculonodular lobe is concerned with balance. Vermis represents the truncal musculature control. Paravermal part is limb musculature, and rest of the cerebellar hemisphere for rest of the body. So it is concerned with motor execution, motor planning, balance, and eyeball movement. Vestibular, we call as a flocculonodular lobe, or it is also called as a vestibulocerebellum. It is concerned with balance and eye movement, while the middle lobe, or we call posterior lobe, that is concerned with motor planning and motor movement, while anterior lobe, it is concerned with motor execution, that is fine movements, etc. Dented nucleus is the largest nucleus. It is important for coordination of limbs movement, while emboliform nucleus is for regulation of ipsilateral extremity. Globus also regulates the movement of ipsilateral extremities, while fastigial nucleus is related to the flocculonodular lobe, so it is concerned with maintenance of posture and balance. Now this cerebellum is connected to lot of structures. This is roughly, it is being given that it receives the input from spinocerebellar tracts, then olivocerebellar tracts, vestibulocerebellar tracts, etc. Then there is cerebellopontocerebellar fibers, and this pontine mosaic fibers, they are connecting the two cerebellar hemisphere. There is also corticopontine fibers which will be connected to this particular nucleus. Then from dentate nucleus you have got a dentatorubro thalamocortical fibers which is connecting cerebellum to cerebral cortex. You have got vestibular nucleus connection to fastigial nucleus of cerebellum. These are all the different multiple connections. So cerebellum is connected to basal ganglia, cerebellum is also connected to cerebral cortex, it is connected to vestibular nucleus, and through vestibular nucleus it is responsible for maintenance of tone, posture and equilibrium. It also takes part in fine movements, skillful movements, and also it organizes the motor skill, the judgment regarding the motor movements. So it gives an order to cerebral cortex, and then that pyramidal tract will execute that on spinal cord. So there are a lot of connections: efferent fibers, efferent fibers, inferior peduncle, middle peduncle, superior peduncle. We are not going into detail regarding that part. So these are efferent connections. We'll be going mainly to the function part of it. So if we divide the function together, so it is for maintenance of tone in the muscle. It takes part in maintenance of balance, that is equilibrium and eye movement. It takes part in coordination of the movement, that is judgment regarding the distance, force, direction, etc. of the movement of the different parts of the body. And it also takes part in maintenance of posture and gait, balance. So indirectly it takes part in maintenance of tone, it takes part in coordination, and it takes part in maintenance of balance and equilibrium during posture as well as gait. So maintenance of tone, posture and balance, coordination of movement, cognitive function and skillful motor movement and motor learning. So those particular are done by cerebellum. So this is indirectly showing you the maintenance of balance and posture, and these are all the different ways in which it gets connected. So cerebellar cortex will be connected to cerebellar nuclei. It will receive an input from motor cortex via pontine nucleus, as well as from the spinal cord via spinocerebellar tracts. And then from a cerebellar nucleus, you will have a connection to the vestibular nucleus, which will be connecting to the reticular formation, lateral reticular nucleus, as well as to the spinal cord. And that reticular nucleus is connected to cerebellar cortex. Also, this cerebellar nuclei is connected to via cerebelloponto, then thalamocortical tracts to premotor cortex, and then via the motor cortex again it is connected back to spinal cord. Because of this complex connection, it will take part in maintenance of tone, posture, equilibrium, coordination, skillful movements, etc. Smooth movement, coordinated movement, all those movements will be done. So it will take part in balance, equilibrium, motor skillful movements. Now cerebellum can be damaged because of infection like bacterial, viral, tuberculosis, can be damaged because of trauma, tumors, which may be primary or malignant, or can be damaged because of the vascular pathophysiology, and the blood supply mainly to the cerebellum is by vertebro-basilar artery territory. It can be also affected because of a B12 deficiency, alcohol, and you can have a degenerative disorders in cerebellum. Also, it can be affected by drugs and chemicals. Among the acquired causes, we already mentioned vascular causes we call strokes, maybe ischemic, hemorrhagic, or maybe because of AV malformation, and this will be in a vertebro-basilar artery territory. We already mentioned infection like viral infection, quite common, bacterial, maybe cerebellar abscess, toxic material like alcohol, anticonvulsant drugs, mercury, lithium, 5-fluorouracil, then malignancy, particularly gliomas, quite common in that area, meningiomas, immune disorders like multiple sclerosis, paraneoplastic syndromes, deficiency disorders like B1 and B12 deficiency, even in case of hypothyroidism, and there are genetic disorders which are autosomal recessive or maybe autosomal dominant. This can also affect and produce cerebellar ataxic syndromes. Now, whenever you want to test for cerebellar dysfunction, there are certain things which are very frequently being utilized. One is gait, second is speech, third is eye, in which we look for nystagmus, and then extremity movements. Most commonly, you can look for nystagmus in the eye. You will have a horizontal or vertical or rotatory nystagmus, which are very, very common in cerebellar disorders. You can observe for the posture, where you can see that the person is having ataxia, person will have an imbalance, and in a gait you will be able to find out a typical drunken person gait, and person will sway from one side to another side. He will have a tendency to fall on the either side, and during gait he will have a truncal ataxia, nodding of the head we call titubation, finger to nose test, that will be in extremities, we call incoordination, will be very clearly demonstrable in upper extremity as well as lower extremity. Speech, it will be a slurred speech. During that different testing, you will be able to find out incoordination, alternating movement will be also affected, we call dysdiadochokinesia. There will be overshooting, undershooting, hyper or hypometria, heel to shin test, heel tapping, which is commonly done in the lower limb, finger nose test, all those will be positive. And person will have a hypotonia. Passive movement will demonstrate that hypotonia, and you will be able to also demonstrate pendular knee jerk. That will be very typical. So now we'll be going through all those different features. You can remember whichever way you want to remember. That is dysdiadochokinesia, that is alternate rapid movements will be affected, and that is called adiadochokinesia or dysdiadochokinesia. Then you will have a dysmetria, means person will not be able to judge the how much distance to move about in upper extremity as well as lower extremity. So you will have a dysmetria, and in that person will have a overshooting, undershooting. Finger pointing will be also abnormal. Person will have a typical ataxia. Rhombus test will be positive with eye open or eye closed. Person will have an unsteady gait. There will be truncal ataxia. There will be arm movements, nodding of the head. In eye, you will have a nystagmus. There will be intentional tremors, which will be demonstrable in very easily demonstrable while in a upper limb while doing a finger nose test, and in lower limb heel shin test. He will have a slurred speech. All these findings will be very easily demonstrable. And you will have hypotonia in muscles. And due to hypotonia, while eliciting the knee jerk, you will get a pendular knee jerk, slow contraction and slow relaxation. And that will be seen for few movements. So that will be very typical, we call pendular knee jerk. There is another way of description: dizziness, ataxia, nystagmus, tremor, imbalance, dysdiadochokinesia, dysarthria, dysmetria. So they say that dizzy and balancing, 3 Ds. So dizzy for dizziness, and is ataxia, nystagmus and tremor. Then balancing is imbalance, and 3D is dysdiadochokinesia, dysarthria and dysmetria. So whichever way you want to remember. So slurred speech, in eye movement you will get a nystagmus. You can have horizontal nystagmus, vertical nystagmus or rotational nystagmus. You will have a limb ataxia, which will be easily demonstrable, we call as incoordination. And in that incoordination you will have a intentional tremor, or we call kinetic tremors. And also there will be dysmetria, means difficulty in judging the distance. There will be overshooting or undershooting while doing a test, that is finger to nose test or heel to shin test. And while doing a rapid alternative movement, you will be able to demonstrate dysdiadochokinesia or adiadochokinesia. And in a gait, it will be a wide base. Person will have a imbalance, and person will be swaying from one side to another side. There will be truncal ataxia, as well as abnormal movement in the upper limb, movement of the head in the form of titubation. All these things will be seen. So dysarthria, dysmetria, kinetic tremors, or we call intentional tremors, nystagmus, abnormal pursuit and saccadic movements, dysmetria, broad base gait. Even while standing also person will be having imbalance, whether with eye open or eye closed, it does not change. So ataxia, tremor, hypotonia, asthenia are the 4 cardinal cerebellar signs. So again, ataxia, intentional tremor, hypotonia and asthenia, very common. And because of that, you will have a titubation, you will have a slurred speech, that is dysarthria. scanning speech, it is also described as scanning speech, nystagmus, dysmetria, slowness of initiating the eye movements, skew deviation may be seen. So you will have a pendular knee jerk and ataxia while erect posture or even while walking. Dysmetria means inability to measure the distance for reaching the intended targets. So that will be demonstrable by while doing a finger nose test or finger to finger test, or in a lower limb, heel shin test, etc. And also intentional tremors will be seen due to dysmetria. You will also have inability to do alternate rapid movement, that is supination, pronation, etc. We will be showing you that. And I will be uploading the video which will be showing you those cerebellar signs. So scanning speech, you can even demonstrate rebound phenomena, means person will not be able to control the antagonist muscle because of effect on flocculonodular lobe, truncal ataxia, staggering gait, nystagmus, Rhombus test will be positive. These are all the terms. Now I am going through all those different terms. Hypotonia and hyporeflexia. Dysmetria means difficulty in judging the distance or the range of movements. That is called dysmetria. And in this dysmetria, when it is overshooted, it is called hypermetria, and underestimation, it is called hypometria, or it is called overshooting, undershooting. Inability to do the alternate rapid movement is called adidacokinesia or dysdidacokinesia. And because of this incoordination, person will also have a tremors, which tremors are mainly during movements. So they are called kinetic tremors or intentional tremors. Usually static tremors are not present. Movement can be decomposed, means all the movements will not be smooth. You will have separation of the movements, like first flexion, then pronation, then flexion at the wrist, etc. So that will be one another thing which you can find in movements during picking up the objects, writing, etc. Disorder of the gait, we have already told you, broad base, unsteady, irregular, staggering, falling on either sides, either on the two sides or forward, slow down, and person will have truncal ataxia. All those things will be seen during gait. So ataxia will be also seen during that gait movement, posture, gait, and person will not be able to maintain the balance. In a speech, dysarthria, and it is described as a scanning speech or slurred speech. Slurred speech. Nystagmus can be rotatory, vertical, or horizontal. When you ask the person to flex against the resistance, you can easily demonstrate rebound phenomena. There will be muscular weakness, asthenia. There will be difficulty in initiating, stopping, or changing the direction, speed, and force during voluntary movement. You can even demonstrate post-pointing test, or also called as a Berenice post-pointing test. Even we call Pronator Drift. Dip tendon reflex will be sluggish or weak, and in a knee jerk you can demonstrate pendular knee jerk. Person, because of the vestibular connection, can even have complaints of vertigo. There will be nodding of the head, we call titubation. These are the big number of findings you can easily demonstrate in a person with cerebellar disorders. As far as ataxia is concerned, to differentiate between cerebellar, vestibular, and sensory, we have already mentioned before that in vestibular, cerebellar, dysarthria will be present, while in vestibular, usually it is absent, sensory also it is absent. Nystagmus in cerebellar is vertical, horizontal or rotatory. In vestibular, it is by and large horizontal, while in sensory, it is always absent. Vertigo is always present in vestibular, may be present because of damage to the connection with vestibular nucleus, while in sensory, it is always absent. Limb ataxia will be very commonly in case of a cerebellar disorders, while it will be absent in case of a vestibular. In sensory, the lower limb will show you limb ataxia. When a person stands, he is unable to stand with eye open or eye closed. With a broad base also, he will find ataxia. While in a vestibular, with eye closed, the person will be getting dropped down, but will be able to stand with a broad base, eye open and wide apart arms. While in sensory, he will be able to stand with the feet together and eye open, but unable to stand with the eye closed. So this will be very typical in sensory, because as soon as the person with a sensory deficit closes the eye, he will have a fall. Even in a vestibular also, the person will be able to stand with little support, with a little broad base. Vibrator in a position sense will be affected in case of sensory, while they will be normal in cerebellar and vestibular. Ankle reflex will be normal in cerebellum, vestibular apparatus, but in a sensory, ankle jerk and knee jerk may be affected, and knee jerk may be depressed, may be lost, or may be absent, but ankle jerk will be more affected as compared to knee jerk, depending upon the severity of the peripheral nerve damage. While in a cerebellar, knee jerk will be pendular knee jerk. This is again same difference between cerebellar and sensory ataxia. I can switch over. These are the gait disorders. Again, comparison with frontal lobe, extrapyramidal and cerebellar ataxia. Person will not be able to maintain the balance, and while walking, he will tend to fall on either side. So he will sway from right to the right in the standing positions, steady on the right leg, unsteady on the left leg. If he has got a left cerebellar tumor, so he will have a tendency to fall on the left side, unsteady on the left leg, and he will have ataxic gait. So depending upon the side of the damage, he will tend to fall on that side. Person will also find difficulty in maintenance of posture. He will have ataxia, and during gait also he will have an ataxic gait. So during examination, we'll examine for equilibrium, coordination, muscle tone and motor skill. We divide into coordination, gait, for coordination, gait, Rhombus test, upper limb, finger to finger nose test, for lower limb, heel knee or called heel shin test. And in upper limb, you can also demonstrate pronator drift. There are other things which can be demonstrable because in coordination, that is dysmetria, tremors, nystagmus, dysarthria, post-pointing test, didacokinesia. While as far as the tone is concerned, with passive movement, you can demonstrate hypotonia, and in a knee jerk, pendular knee jerk. As far as equilibrium is concerned, Rhombus test, and in a gait, and at a static posture also you can demonstrate. That is by doing a Rhombus test. So now we are going through all those different tests one by one. So for coordination, you can go for Rhombus test, ataxia, dysmetria, tremors, dystonia, rebound phenomena, finger nose test, heel shin test, and didacokinesia. These are all the different tests very commonly done for coordinations. For posture and equilibrium, best is ask the person to stand in a erect posture. Person will have a little stoop forward. He will be ataxic, and you might see an abnormal movements. Second best simple test is a Rhombus test. Even with a broad base, person will be not be able to maintain the balance, whether with eye open or eye closed. Classical in case of a cerebellar ataxia. But you will have to differentiate from vestibular and sensory. In sensory ataxia, person will try to stand with a little broad base, eye open. As soon as he closes the eye, he will have a fall. While in a vestibular, person will try to maintain the balance with little broad base, eye open and little support. While in cerebellar, whether with eye open or eye closed, whether with limbs together or with broad base, person will have ataxia. In an cerebellar ataxic gate, person will try to fall on the side of the damage. If there is a unilateral damage, and he will try to fall on the both the side if there is a bilateral damage or there is a damage to vermis. And particularly in a damage to vermis, person will try to tend to fall backward. If you examine the tone during passive movement, you will be able to demonstrate hypotonia. And because of hypotonia, in knee jerk, you will be able to demonstrate pendular knee jerk. During talking to the person, when he answers, the speech will be slurred and it is also described as a scanning speech. He may complain of vertigo. While any particular movement, you will be able to see the intentional tremors. And particularly this will be well demonstrable when you try to demonstrate dysmetria, incoordination and intentional tremor in doing finger nose test, and in lower limb heel shin test or heel knee test, whatever word you utilized. Static tremors are less as compared to intentional tremors. Intentional tremors will be there, more common when the person is trying to do some act, and that is very common in cerebellar disorders. In post pointing, when you ask the person to keep both limbs, both upper limb, identical position, one limb will have post pointing, and that is also given a name Berenice post pointing. And we have already told you that while doing some action, there may be decomposition of movement, there may be asynergia, and you can have a dysmetria, means person cannot judge the distance and direction. As far as the eye movement is concerned, you can have a horizontal, rotatory or a vertical nystagmus, very commonly seen in a cerebellar disorders. So in upper limb, whenever you want to demonstrate incoordination, you can go for dysmetria, dyssynergia and intentional tremor together can be seen while doing finger to nose test or nose to nose finger nose test or finger to finger test. So when you are asking a person to touch the finger to finger, it is called finger to finger test. When you are asking the person to touch the finger and touch his nose, means he is touching your finger with the upper limb finger and then he is touching his nose, that is called finger to nose test. If it touches his nose, then your finger and back to the nose, then it is called nose finger nose test, whichever test you do. While coming to the target, person will have an intentional tremor, dysmetria, and also there will be undershooting, overshooting, we call as a hypometria or hypermetria. Any one of those words you can utilize. You can use the word hyper means overshooting, hypo means undershooting, and at that time you will see also intentional tremor. And when you ask the person to do alternate rapid movement like tapping in the palm, that is called didacokinesia, or finger counting, and person will not be able to do rapidly, that is called dysdidacokinesia or adidacokinesia. Also in a rebound test there can be overshooting or undershooting. So while asking a person to flex the arm against the resistance and you suddenly leave that resistance, person will have either overshooting or undershooting. And we have already mentioned pass pointing or Berenice pass pointing, or also there is one we call as a Pronator Drift. So you are asking a person to outstretch the arm and maintain that position. So person will have either post pointing, means the hand will be outstretched, arm will have a different position after elevation. That is called Berenice pass pointing test. And if you ask the person to maintain the same position, the arm will slowly pronate, and this is called Berenice pass pointing test, and pronation is called Pronator Drift. If you ask the person to draw the circle, person will not be able to draw that by tapping. That is also demonstrable in because of what we call as incoordination. This will be all the tests which you can do in upper limb. In lower limb, you can do heel to knee test or heel to knee to toe test, kicking examiner head with a foot, writing figure 8 with the foot. You can do dysdiadochokinesia in a lower limb. You can also look for the rebound phenomena in lower limb. You can ask the person for holding the leg in one particular position of holding the leg in one position. In that also you will find same like in upper limb, you will have a pass pointing test, or you will be also able to demonstrate that person will not be able to hold both the legs in the same position. And when you elicit the knee jerk, you can elicit the pendular knee jerk. This will be the incoordination test in lower limb. While gait and erect posture, Rhombus test, tandem gait will be able to demonstrate incoordination and ataxia very nicely. So these are all the different tests in upper limb: finger, nose, finger to finger, making a circle in the air with finger, diadochokinesia. In lower limb, knee heel test, making a circle in the air with the toe, and whole body when you want to check, Rhombus test and tandem walking. So these are all the things which you can divide: upper limb, lower limb, and whole body in coordination test. So this is rapid alternate movements. This is counting the finger. This is heel. Heel is stuck to the knee, so heel knee test or heel shin test or heel knee toe test. So these are all the name given. Rapid alternate movement you can do. This is finger to finger test. Then when person touches the finger of the examiner and then touches the nose, it is called finger nose test. This is heel. It touches the knee and then along the shin. So heel shin test or heel knee test or heel shin knee test, etc. All those different. Heel to shin, nose to the examiner finger, so finger nose test. These are all the different name given. These are alternate movements, so called as a diadochokinesia, and if it is absent, dysdiadocho or adiadochokinesia. So dysmetria can be easily demonstrable while doing a finger nose test. You can do the same test while tapping on the thigh region, alternate movements. Finger tapping test. This is that alternate movements. Alternate movements. You can test. Rapid alternate movements. Counting the finger. You can do in upper limb, you can do in lower limb. Rapid alternate movement. Pronation, supination. Pronation, supination. You can do on the palm also. This is finger nose test. He touches the finger of the examiner and then back to the nose. So that is called finger nose test. This is touching the finger to the nose. So finger nose test. This is touching the finger. So finger to finger test. Here you can see touching the finger and nose, finger nose test. Here touching the finger. Now he is having intentional tremor. And he cannot judge the distance also. Undershooting, overshooting, we use another word, hypo and hypermetria. This is finger nose test. Finger to nose. Finger, and then if it touches the nose, finger nose test. And if it touches only finger, finger to finger test. And in a lower limb, we have already told you, he lifts the heel, he touches the knee, so it is also called heel to knee test. And when he pushes down, heel to shin test. Then for rapid movement, heel tapping test. This is from knee to the toe. So heel to knee test. So these are all the different names given. You can go for rebound phenomena. So when you apply a resistance and suddenly leave it, you will have overshooting or undershooting, and that is because of dysmetria. Rebound test. So when you leave it, it will just overshoot. You can do what is called as tapping test. You push it down. Wrist tapping test. You will have overshooting. This we have already mentioned, that while erect posture, broad base will be common, very common, and person will have ataxia even with a broad base with eye open, and person will have a tendency to fall on either side. If right side is damaged, he will have a tendency to fall on the right side. If left side is damaged, tendency to fall on the left side. And if vermis is damaged, he will have a tendency to fall on the back. And if both lobes are damaged, both sides. That same thing can be demonstrable in a rhombus test, whether with a broad base or with a legs together, whether with eye open or eye closed, he will have ataxia. Typical ataxia in all, whether with narrow base, broad base, eye open or eye closed. So whether with eye open or eye closed, person will have ataxia. And for differentiating between vestibular and sensory, you can utilize modified rhombus test. As far as gait is concerned, we already mentioned that person will be walking with typical drunken man gait, we call. He will have a swaying from one side to another. You can demonstrate while tandem walking or while walking on a straight line. You can easily demonstrate that. These are all the different type of walking by which you can exaggerate that findings. Whether by tandem walking or walking on the toes or walking on the heel or hopping. And person will have a typical truncal ataxia and tendency to fall on the one side or on both the sides. You can also demonstrate pronator drift when you ask the person to outstretch the arm and maintain the position. You will have one arm affected side will drop down and there will be pronator drift. This is also called as a Berenice pass pointing and also labeled as pronator drift. Berenice pass pointing or Berenice sign or even pronator drift. Very typically demonstrable. Very typical. Whether there will be up drift or down drift. As far as location is concerned, if there is ipsilateral damage, you will have on the same side tendency to fall. If vermis is damaged, you will have a tendency to fall on the back. But ipsilateral damage will be more common in infarct, neoplasm, abscess or maybe demyelination. While vermis damage is more common with truncal, with alcoholism and B1 deficiency. While medulloblastoma is again common to damage the caudal vermis. Pancerebellar damage is more common with toxins, metabolic products, infection, autoimmune disorders. And peduncle damage is very common in, again, vascular disorders. And we already mentioned that if you have got a posterior flocculonodular lobe, you will have nystagmus, gate dysfunctions, ocular reflex will be abnormal, and you will have a ataxic gate. If you have got a vermis damage, you will have a more of truncal ataxia and gate ataxia. And you have got hemispherical damage, you will have more of dysarthria, hypotonia, intentional tremors, dysdiadochokinesia, dysmetria, all these findings will be there. We already mentioned vermis will be bilateral signs and tendency to fall on the back. If it is unilateral damage, tendency to fall on one side. So hemispherical damage, tremors, ataxia, dysdiadochokinesia, pendular knee jerk, those findings will be more common. While titubation, truncal ataxia will be more common with vermis damage. So these are all the things which you can get in a hemispherical damage, that is dysmetria, dysdiadochokinesia, hypotonia, then tendency to fall on one side. You can have, if there is a unilateral damage, nystagmus, midline damage, truncal ataxia, titubation, ataxic speech, those will be more common. So I end my lecture here. I thank you all for taking out time. I know that your time is valuable. I appreciate for that you have spent some of the time with me. If you like this particular lecture, please don't forget to press button like, subscribe. You can give your suggestions, and if you feel, you can share with your friends also. I will be uploading a video which will show you some of the cerebellar signs in demonstration. You can go through, you will understand much better. See you in next lecture.